You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 11th, 2022. This week, 2 announcements: AFib screening, CTA, stroke prevention, broken observational studies, and medical writing. I want to make first 2 announcements. This Week in Cardiology will take next week off as I'm traveling to Denmark to speak. Second announcement is that I want to lead with the thanks for the comments that we're getting on the This Week in Cardiology link on the heart.org Medscape webpage, and also for some of the kind reviews on Apple Podcasts. Thank you very much. These things really help others find the podcast. All right, first topic, AFib screening. Yet another trial has been published on AFib screening, and yet another trial has failed to show AF screening benefits patients. Circulation published a VITAL AF trial from researchers at Harvard. It was a point-of-care screening with a handheld single ECG at the time of a primary care visit. The question of the study was simple. The primary outcome was the incidence of newly diagnosed AFib. This was a pragmatic cluster randomized trial in which the authors randomized 16 clinics to AFib screening with a cardiomobile device during the time that the patient came in and was taking vital signs. The control group was just usual care. Cluster randomized trials are pretty nifty and deserve just a brief word. Here, the randomization is at the clinic level, not patient or clinician level. Cluster randomized trials are useful for studying methods or approaches to patient care as opposed to evaluating a specific defect of a medicine or procedure. These types of trials would have been perfect to use during the pandemic to study system-wide things such as non-pharmaceutical interventions. Now, the inclusion criteria of VITAL AF enriched the cohort with patients likely to have AFib. That is, they screened those over 65, which is smart. You wouldn't want to screen young people. Cluster randomization of that many clinics produced big numbers of patients, about 15,000 patients in each group. And the primary outcome of newly diagnosed AFib occurred in 1.72% of individuals in the screening arm versus 1.59% in the control arm. And the risk difference is 0.13%, and this did not reach statistical significance. The p-value was just about 0.4. The authors did sensitivity analysis, such as intention to treat versus as treated. They did multivariable analyses, and these showed similar non-significant results. This is a solidly null result, not even close to significance. As such, the proportion of individuals with new AF who were initiated on oral anticoagulation also did not differ in the 2 groups. And the authors rightly concluded, quote, screening for AFib using a single lead ECG at primary care visits did not affect new AFib diagnoses among individuals aged 65 years or older compared to usual care. Now, however, I am sad to report that the authors resorted to spin. In the results section, in the paragraph, right after reporting the null results, the authors tell us the results by age, and in patients greater than 85, the results favored screening. The problem, of course, is that this group was the smallest group, representing only 1,200 of 15,000 individuals. Now recall that spin is defined as language that distracts from the non-significant primary endpoint, and this is clearly spin. And in the news story, the spin made the first and second paragraphs as well as the title of the piece. Now, I did an altmetric search on the paper. An altmetric is a measure of the attention it gets, and it looks at the news coverage and tweets and blogs, etc. This paper was picked up by 7 news outlets, and every single one of them led with this quote, "Handheld ECGs may be most effective in older adults." Now, it's interesting here that Twitter, of all things, seemed to be more accurately emphasizing the overall primary null results. So 4 comments. First of all, I want to say congratulations to the research group. Researchers who conduct trials to answer important questions deserve kudos regardless of the results, and I just wish that was the norm. Why can't we just say this? We thought a single lead, super nifty, 1 lead ECG used in primary care clinics might help identify more AFib. But it didn't, and now that's an important thing to know. Why can't that be enough? Knowing what doesn't work represents a huge advance in biomedicine. Then there would be less incentive to dip into small subgroups to find, quote, positive findings. Okay, second comment, I'm not surprised by the primary outcome finding. Why? Well, because of the control arm. I mean, if a patient cannot expect a clinician to pick up new AFib, well, that would be a pretty low standard. I mean, modern blood pressure cuffs can alert for an irregular rhythm. And if a patient gets even a modicum of an exam, a palpated pulse, a stethoscope even outside the close, a trained clinician ought to be able to feel or hear an irregular rhythm. I mean, the cardiomobile device and these various smartwatches that can record an ECG, I think they have their greatest utility in diagnosing people with symptomatic palpitations. A patient feels something in their chest. They record the rhythm. You get to make a diagnosis and often avoid the need for medical grade monitoring, and that is cool. But as a screening device, intermittent recordings are going to be challenged, right? Recall that most asymptomatic AFib is paroxysmal. A device that checks the rhythm once or twice daily stands a good chance of missing intermittent AFib. Okay, final comment and I'll move on. I think we now have enough data on AFib screening as a means to reduce stroke. It just doesn't. I wonder if the next frontier of AF screening is to determine if picking up extra AFib may lead to important behavioral changes, such as an increase in exercise, improvement in diet, sleep hygiene, maybe adherence to medicines. In an ideal world, a new AFib diagnosis ought to lead to greater attention to these cardiometabolic risk factors, and doing that could have huge effects on overall quality of life. All right, next topic is coronary CTA versus invasive cardiac angiography, or ICA. The New England Journal of Medicine has published a very large pragmatic RCT led by a German group in Berlin, and it's called the Discharge Trial. The comparison here was CTA versus angiography as an initial imaging strategy to guide treatment of patients who had stable chest pain and an intermediate pre-test probability of having obstructive disease. The primary outcome was a good one. It was CV death, MI, and stroke over 3.5 years. Investigators also looked at procedure-related complications as well as angina. It was done in multiple centers in Europe, and about 3,500 patients were randomized. These were about 60 years old, 56% female, and get this, more than a third of these patients had non-anginal chest pain, and only a third had undergone stress testing. Now, this was a superiority trial. It was powered to show that CTA reduced clinical outcomes over invasive angiography. Okay, the results. Major adverse cardiac events occurred in 2.1% in the CT group and 3.0% in the angiography group. The hazard ratio is 0.70, so that's a 30% reduction. However, the confidence intervals were wide and went from 0.46 to 1.07. That yielded a p-value of 0.10, so above the 0.05 statistical threshold. This 30% relative risk reduction and 0.9% absolute risk reduction obviously did not reach statistical significance. Major procedure complications, not surprisingly, were higher in the angiography group, 0.5% versus 1.9% CTA versus angiography. There were no significant differences in angina during the last month of follow-up of the trial. And a couple other notes on results. Okay, The Kaplan-Meier curves of the primary endpoint began to separate at 6 to 12 months. Now think about that for a second. A diagnostic test, not an intervention, began to reduce hard outcomes at 6 months. I'll come back to that. And this, only 22% of the patients in the CTA arm ended up having an angiography. That's pretty good. And the frequency of coronary revascularization was 24% lower in the CT group than in the angiography group, 14.2 versus 18.0%. The authors write in their discussion this line, quote, "Our trial confirmed the safety of a CT-first strategy and showed results that were similar to those with angiography." And media coverage led with this line, "CT appears preferable to standard cath-based angiography for the initial evaluation of most stable intermediate risk patients with angina-like symptoms." Now my comments. First, let's talk about pragmatic trials. I like pragmatic trials because they often lead to better external validity or generalizability because they simulate normal practice patterns. And when I dug into the methods and supplements, this appears to be an internally valid trial. For instance, loss to follow-up is quite low. But some of this trial's core questions and interpretation perplex me. I don't know what the European norms are, but here in the US, the initial evaluation of patients with typical, atypical, and non-cardiac chest pain is stress testing, functional testing, not angiography. I can't write in a chart that a 61-year-old has atypical chest pain and haul them off for a cath. No payer would allow it. The peer-to-peer doctor would ask, "Hey doc, what did the stress test show?" And to be honest, I think this is correct. For if you have an intermediate probability of coronary disease in a normal low-risk stress test, what are the indications for defining the anatomy anyways? I think the better pragmatic question for me would have been CTA versus stress testing. Now, the second perplexing thing is the notion that an imaging test can reduce major adverse cardiac outcomes. The authors of Discharge powered this study to test the superiority of an imaging test to reduce hard outcomes. They also had to know that patients with a pretest probability of 36%, that's what the average pretest probability was, are going to have low event rates. So they expected CTA, a CT scan, would reduce MACE by 40%. Okay, I'm just a regular electrophysiologist, but don't we already know that revascularization, which is actually an intervention, did not reduce MACE at all in Courage, Berry 2D, and ischemia, and these were high-risk patients. So if interventions don't reduce MACE in higher-risk patients, how do we expect an imaging test to reduce MACE in intermediate-risk patients? All right, third point here, and this I got some help from Sanjay Kaul at Cedars-Sinai. The narrative of this trial seems to be, okay, CTA did not reduce MACE, but it was as good as angiography with less complications. But that is not technically the correct interpretation of a superiority trial, is it? Instead, shouldn't we say CTA was not shown to be superior to angiography? And you can qualify this by noting the event rates were lower than expected in the angiography arm, which of course would reduce the power to detect real differences if there were any. Kaul says the results are best called inconclusive, and words like similar, comparable, as good as don't apply. And my final comment is, I worry a lot about the expansion of CTA. Yes, it is useful for diagnosing left main disease, but the problem, at least in the US, is the presence of coronary artery disease often begins a cascade of downstream intervention. And so often the coronary disease is incidental. For instance, in my world, a patient with AF gets a CTA to rule out coronary disease. He's found to have mid-LAD disease, and boom, he gets a stent, despite having no angina, being on a statin, and the results of ischemia trial. Now this patient faces dual or triple antithrombotic therapy, but the problem was AF. Now, having looked at the functional versus anatomic studies for diagnosing CAD, I'm not convinced CTA should be dominant. That's because you get a ton of information from functional testing. You get exercise capacity, diagnosis of arrhythmia issues, and a measurement of the degree of ischemia, and I think these are useful things to know. This is a complicated trial and interpretation, so let me know what you think in the comments. Third topic is reducing stroke after transcatheter aortic valve implantation TAVI. JACC Intervention has published a new observational study which purports to show that an add-on device is helpful for reducing stroke. One of the most feared complications of TAVI is stroke. And while rates of post-TAVI stroke have decreased somewhat, they have remained sort of flat at around 2%. And actually, I'm quite surprised that there aren't more strokes with this procedure given what actually goes on in the proximal aorta and valve. I mean, I don't mean to sound unscientific, but the new valve is sort of squished into a fibrotic calcific current valve, and you'd expect tons of debris to go northward to the brain. In fact, debris is thought to be the main mechanism of stroke. So it makes sense that a cerebral protection device as part of a filter to catch this debris before it hits the brain would reduce stroke. And strengthening that plausibility argument on stroke reduction is the fact that studies show that these devices actually catch debris. However, small trials and observational studies have failed to show a reduction in stroke or mortality, despite the fact that the device catches debris. A meta-analysis of 6 trials found no evidence of difference between patients with and without a cerebral protection device for the primary composite outcome of stroke and mortality at 30 days. And a recently published large registry observational study found no association between embolic protection devices used for TAVI and in-hospital stroke. Okay, now to the current research letter published in JACC Interventions. It was from the TAVI team at the Cleveland Clinic, and they used a readmissions database between the years 2018 and 2019 to study the association between an embolic protection device and stroke-related mortality after TAVI. Now, this is administrative claims data. They selected patients who developed stroke during the index hospitalization and compared patient characteristics and treatment and outcomes between stroke after TAVI with the device and without the device. Their primary endpoint was mortality, not stroke, and the total sample size was a little tricky. It was 136,000 TAVI recipients, but that's actually not the total sample size. I'll get to that. Now, this was a non-randomized comparison. There were 10,000 patients who had the device and 126,000 that did not. So already you're looking at a seriously unbalanced groups. Now, here is the key data point, though it is not their endpoint. The rate of stroke was nearly the same. The rate of stroke was nearly the same, 1.85% with a protection device, 1.94% in those who did not have it. And keep these results in mind when I tell you the primary outcome. Patients with stroke after TAVR with the embolic protection device had significantly lower in-hospital mortality than those with stroke after TAVI without the embolic protection device. And the difference was huge, 6.3 versus 11.8%. This difference persisted after adjustments. And despite this massively lower rate of death in the hospital, the 30-day mortality was not significantly different. Okay, I think this paper offers a good lesson in critical appraisal, and to be totally fair to the authors, they spent a huge paragraph in the research letter telling the readers to be cautious in their interpretation. Because, they wrote, despite the large sample size of total patients, the numbers who had stroke, which only about 1.9%, is quite small, and that led to wide confidence intervals, and despite a halving of mortality rates, 6 versus 12%, the p-value barely makes significance at 0.049. So think about that. You reduce mortality by a whopping 6% in absolute terms and barely reach significance. That means there's a lot of noise in the signal. The authors also note the limitation of administrative claims. You don't get data on the amount of neuro impairment, imaging findings, or details of the procedure from claims data. But my friends, there are more obvious reasons this is noise rather than signal. Embolic protection devices work by reducing stroke, and if you reduce stroke enough, you could possibly reduce death. But it would have to be a heck of a reduction in stroke to lead to lower death because of the many competing causes of death of old people. Stroke is only one way an older person can die. Recall that in the LAOS 3 trial, which was surgical left atrial appendage closure at the time of heart surgery, this trial showed a large and statistically robust reduction in stroke but had no effect on mortality. Again, because old people have many ways to die. That does not mean stroke isn't an important endpoint to reduce. It is. Now, in this study, the stroke rates were the same whether or not an embolic protection device was used, and I don't see how you can reduce death if the stroke rates are the same. The authors say it might be because the device catches large debris, but if this were true, would we not have similar signals in the many studies done before? Now, here's another reason this is likely a spurious finding. My structural partner says we don't use a lot of embolic protection devices because of cost. The margins for TAVI are razor thin, and adding another $2,000 is not feasible unless there's compelling clinical reasons to do so. So the selection of embolic protection devices is not random. Big, wealthy centers like Cleveland Clinic use these devices more than community programs. And is there any reason to doubt that the patients done in Cleveland Clinic are perhaps healthier than those in community hospitals? Of course they are. Dr. David Cohen, an academic interventional cardiologist, had a beautiful quote on Twitter this week about observational studies. He wrote, "Some of them are right, I just don't know which ones." But here I would argue that this one is highly likely to be wrong due to bias. But here's the thing. A major journal publishes it. Media covers it. Readers get the top line. Regardless of the limitations, readers see big-name people publishing data that has a positive top line. This is how therapeutic fashion of unproven therapies gets ensconced into the norms. My advice to you all is this. When you read a study, always be asking yourself whether this is marketing or science. Okay, final brief topic. It's about writing in medicine. Medscape Medical News is a story on the Yale Internal Medicine Residency Writing Workshop. The idea being that it gives residents the tools they need to craft meaningful narratives about the human experience surrounding medicine, giving these physicians the agency to tell their stories in meaningful ways. The program began with Yale's internal medicine program, but has now grown to include residents of many specialties and other programs. I love writing. I've advocated for young people to write more than they do. And personally, I regret not starting to write earlier in my life. I mean, what makes medicine so special and meaningful are the stories, the human stories, both the joyous and the tragic. I wish I'd spent more time chronicling my times at Hartford Hospital and Wishart Hospital and the VAMCs and IU Hospital. So, on the one hand, I welcome such programs. At minimum, I hope such efforts lead to improved notes in the chart, which the EHR has turned into unreadable gibberish. So to any of the young listeners out there, please learn to tell a brief story in a chart. Don't worry about the form, the syntax, the grammar. They're less important than telling us something important about the person or the event. Write something that makes us think a human is caring for this person. Now, 3 cautionary notes. First, there is a craft to writing well, but the craft part I think is overemphasized. Far more important is simply putting butt to chair and starting. You will learn the craft as you go. 3 simple Mandrola rules. Write mostly short sentences. Reduce jargon and words that end in ION. A word like revascularization gives me a rash. Pick up a journal like JAMA or Annals or Health Affairs and read a health policy piece. Then, don't write like that. Read writing books, Bird by Anne Lamott, On Writing Well by Zinzer, Roy Peter Clark's How to Write Short are 3 of my favorites. Roy Peter Clark's analysis of Tom Petty's song Free Falling as an example of beautiful short writing is worth the price of the book alone. Strunk and White were not my favorite. Okay, second note. As a middle-aged person, one who's going to need medical care soon, I would still rather have a knowledgeable doc than a great writer for a doc. And training is one of the only times you'll have dedicated time to learn from master clinicians, and I would not want writing to be a major focus. Learning how to be a clinician is the most important thing. But you can learn to write gradually without compromising your once-in-a-lifetime chance to learn how to help people. Writing well is not a sprint, it's a marathon. And the third note, in this day and age, privacy has never been more important, and I see a lot of stories on social media that are clear violations of privacy. Don't do this. For example, we did our first XYZ procedure today. That, of course, identifies the patient, and it doesn't matter if they gave you permission, you shouldn't be asking for permission. So that's it for this week in cardiology. I went a little longer this week because I'll be taking next week off. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, give us a rating, write us a review. These things really help others find us. We'll see you again in 2 weeks. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.